Good afternoon to all. I will be dealing about the evaluation of the visual fields. So assessing the visual field is much essential in glaucoma because the damage to the retinal nerve fibers initially affects the visual fields rather than the visual acuity. So the role of the perimetry is to identify the field defect. Is a field defect due to glaucoma and is a field defect progressing or not? The most commonly used is Humphrey automated perimetry, and the results needs a systematic analysis. Usually it is divided into multiple zones for better interpretation. Just as salient features of each zone, I will be elaborating. The first zone is the patient's data and the test parameter. The most important is the age of the patient should be correctly entered because the machine compares it with the age match controls. And the refraction should be done appropriately before doing the visual fields. The pupil size ideal is 2.5 to 4 millimeter. A small pupil may give a false scotoma. As you see in this patients, the numerous edge scotoma occurs when the pupil diameter is around 1 millimeter. When the same patient undergoes the fields again with a pupil diameter of 3 millimeter, the edge scotomas has vanished. The main indices to check the reliability of the visual field is fixation loss, false positive error, and false negative error. Initially, the fixation loss was judged with the patient's response on the target projected at the blind spot, but nowadays with the gaze tracking technique, the visual fixation loss is better assessed. A loss of more than 33% is very poor reliability. False positive errors occurs mainly in the happy trigger patient when the patient responds even without the presentation of a target. This appears as a white scotoma. Here you can see the white scotoma because of the high retinal peripheral sensitivity, which is equal to the foveal sensitivity. That is very unusual. So false positive of even more than 15% gives poor reliability because it hides the scotomas. False negative error mainly occurs because of the patient's fatigability, where the patient fails to respond to suprathreshold stimulus, which he has responded earlier to his lower stimulus. So it typically occurs like a clover leaf pattern with the edge scotomas. A false negative of more than 33% gives a poor reliability of the fields. So with these reliability indices, we can assess further the field defects. The raw data gives the actual threshold score for each point. The numerical represents the decibels. So higher the number, higher is the retinal sensitivity. Lower is the number, lower is the retinal sensitivity. So usually the fovea has the highest retinal sensitivity. The maximum record in young patients is around 40 decibels. The grayscales give just a graphical representation of the threshold. One should not judge the extent of the field damage with the grayscale. The deviation plots are much important to analyze. Here, each retinal sensitivity point is compared to the age match control. So it is given as a numerical plot as well as a deviation probability plot. A probability of less than 0.5% in a normal patient has been represented as a black square. The pattern deviation plot mainly focuses on the localized deviation. This is done by correcting the deviation of the 7th highest threshold and adjusting the entire field by that value. So why is it important to have a pattern deviation plot? The total deviation plot have the depression due to both generalized depression and localized scotomas. So hence the patient with the cataract and the glaucoma, the depression due to glaucoma is hard to assess. So in the pattern deviation, by negating the generalized depression, the localized field defect due to glaucoma can be easily assessed. The global indices are single numbers, which helps us give a better clue about the visual fields. The mean deviation is an average of all the numbers shown in the total deviation, and it indicates the overall deviation. So it is the high normal range of around 0 to -2 decibel, and the high negativity is seen both in the generalized depression as well as in the localized depression. Whereas in the pattern standard deviation, the degree of difference between individual point within the field is analyzed. So it indicates more of the localized field defect. But this is not of a much help in advanced glaucoma, where there is a generalized retinal sensitivity decrease. The short-term fluctuation is usually assessed as the intra-test variation in full threshold strategy, but it is not of much value and not recorded in SITA strategies. So the visual field index is a global parameter. It is adjusted for age and it is represented in percentage. This gives us a better clue of the visual field available in the patient. So it is calculated from the pattern deviation map with more important to the central point. The normal field is around 100% and perimetrically blind gives us a 0% visual field index. The glaucoma hemifield test assesses the zones in the superior and the inferior hemisphere. Since the glaucoma affects the horizontal nerve fibers in an asymmetrical way, this gives us a better knowledge about the glaucoma field defect. So the outcomes may be within normal or borderline or outside normal limits or general reduction of sensitivity. So with these basic ideas, how to detect a field defect, whether it is due to glaucoma. Usually glaucoma affects the superior and the inferior arcuate fibers, giving us some typical field defects. Example, central paracentral scotomas, sedal scotoma, where the scotoma arises from the blind spot into the germs area, which is 10 to 25 degree, and which may progress into the superior arcuate scotoma up to the horizontal raphe. It can lead into a biarcuate scotoma, and finally only temporal field of vision is left behind. In initial early glaucoma, some patients will have scotomas in the nasal field, which is commonly called as a nasal step. This occurs mainly because of the horizontal asymmetrical involvement of the glaucomatous nerve fibers. And the Anderson criteria helps us to judge the glaucomatous field defect better. So according to the criteria, the 3 non-edge points with at least 2 points with the probability less than 5% and 1 point with the probability less than 1%. This applies mainly for the 30-2, but in 24-2, even the edge point should be considered. And the glaucoma hemifield test should be outside normal limits and the abnormal PST of around P less than 5%. But in a highly suspicious case, even one criteria, if it is present, it leads to the glaucoma diagnosis. So before testing, we should choose appropriate testing pattern. So commonly used patterns are in glaucoma center 24-2, 10-2, and the macular program. So here is a patient with an advanced glaucoma where the visual field could not predict the pattern deviation in a 24-2 because of the generalized retinal sensitivity decrease. When the same patient underwent the 10-2, the better retinal sensitivity was detected in the macular area. This helps us to judge for the treatment. And the patient with the maximum medication who cannot control to get the target IOP, whether the surgical intervention helpful depends mainly on the macular sensitivity. So does that mean all the advanced glaucoma only needs 10-2 and the early glaucoma should be ordered for 24-2? So here is a patient with the early glaucoma with the inferior rim thinning and the inferior RNFL defect who had few central scotomas. The mean deviation in the 24-2 is -4, which points towards the early glaucomatous. So when the same patient underwent a 10-2, more scotomas, that to absolute scotoma, were picked within the 5-degree field. This implies that whenever there is a central scotoma in the 24-2 or clinical suspect of RNFL defect close to the macular area, a 10-2 and a macular program gives us a better idea about the retinal sensitivity near the macula. So always correlate with the clinical findings. So this is a patient referred to us for a glaucoma suspect with a large disc and a large cup with a mild temporal cadar. And the visual field then gives left us with the left hemifield field defect. That is left homonymous hemianopia. And the patient, when underwent MRI, was diagnosed with acute infarct in the occipital region. So thus implies the rule that always neurological defect follows the vertical meridian and the horizontal, and the glaucoma follows the horizontal meridian. So is this a field defect, superior arcuate defect due to glaucoma? When we examined the nerve, it was the anterior ischemic optic neuropathy. The field defect is the altitudinal field defect due to the optic neuropathy. So here is a similar patient with the inferior vein occlusion causing a superior scotomas. Here is a patient, young patient, glaucoma suspect whose previous fields were normal suddenly came with a field defect inferiorly. When we investigated the patient, it is because of the mask the patient was wearing leading to this inferior arcuate scotoma. So always make the patient comfortable during the testing. It is as important as analyzing the result. Visual fields also helps us to analyze the progression. With the newer software, there are two analyses, mainly event-based and trend-based analysis. The overview pattern, which was used earlier, doesn't give us much clue on the progression of the analysis of the glaucoma. So in GPA, glaucoma progression analysis event based, the current visual field is analyzed with the baseline visual field and with a set of stable glaucoma patients. And it is given as a possible progression or likely progression. So with this, since the time is up, so always correlate the visual fields with the clinical finding, and reliability should be assessed, and don't judge the depth with the grayscale, and test with appropriate strategy and point pattern. And the follow-up is regularly is needed to assess the progression.